Chapter 7 Antidepressants. We will start with some general principles. First, response. When treatment of depression or any other episode results in at least 50% of improvement in symptoms, it is called a response. Such patients are better but not well. Previously, this was considered the goal of depression treatment. Remission. When treatment of depression results in removal of essentially all symptoms, it is called remission for the first several months. Recovery is removal of essentially all symptoms and sustained for longer than 6 months. However, they are not cured since depression can still reoccur. Remission and recovery are now the goals when treating patients with depression. Relapse. When depression returns before there is full remission of symptoms or within the first several months of following remission of symptoms, it is called relapse. Recurrence. When depression returns after a patient has recovered, it is called recurrence. How well do antidepressants work in the real world? According to the study trial of antidepressants, remission rates in MDD are as follows. Approximately 1/3 of depressed patients will remit during treatment with any antidepressant initially. Thus, after 1 year of treatment with 4 sequential antidepressants taken for 12 weeks each, only 2/3 of patients will have achieved remission. Common residual symptoms in patients who do not achieve remission are insomnia, fatigue, painful physical complaints, problems concentrating, and lack of interest. And the least common residual symptoms are depressed mood, suicidal ideation, and psychomotor retardation. The concept of disease progression in major depression is controversial. Chronicity of major depression, development of treatment resistance, and likelihood of relapse could all be reduced with aggressive treatment of major depressive episodes that lead to remission of all symptoms, thus potentially modifying the course of the illness. Antidepressant classes. The classical antidepressant action is to block one or more of the transporters for serotonin, norepinephrine, and or dopamine, consistent with the monoamine hypothesis of depression. Problems with this hypothesis is action of antidepressants can raise monoamine levels quite rapidly in some brain areas and certainly sooner than the antidepressant clinical effects occur in patients weeks later. And the answer might be that the acute increase in neurotransmitter levels cause adaptive changes in the neurotransmitter receptor sensitivity in a delayed time course consistent with the onset of clinical antidepressant effects. Specifically, this acutely enhanced synaptic levels of neurotransmitters could lead to adaptive downregulation and desensitization of postsynaptic neurotransmitter receptors over time, resulting in antidepressant actions, and this might also explain the development of tolerance to the acute side effects. This adaptive changes in receptor numbers and sensitivity is likely the result of alteration in gene expression, including not only turning off the synthesis of neurotransmitter receptors but also increasing the synthesis of various neurotrophic factors such as BDNF. Selective serotonin reuptake inhibitors or SSRIs. To give some perspective, SSRI prescriptions in US alone occur at the rate of 6 per second 24/7 around the year. There are 6 principal agents in this group that all share the common property of SR inhibition. However, each of these 6 drugs also have unique pharmacological properties. Let's first discuss what the 6 SSRIs have in common. Although the action of SSRIs at the presynaptic axon terminals has classically been emphasized, it now appears that the events occurring at the somatodendritic end may be more important in explaining the therapeutic actions of the SSRIs. In the depressed state, serotonin may be deficient both at the presynaptic somatodendritic area and in the synapse itself. Receptors may be unregulated and neuronal firing rates may be dysregulated, contributing to regional abnormalities in information processing and the development of specific symptoms depending upon the region affected. SSRI acutely causes 5-HT to rise to much greater levels at the somatodendritic area located in the midbrain raphe and does not immediately lead to great deal of serotonin in many synapses. Serotonin receptors in this brain area have 5-HT1A pharmacology. Increased 5-HT levels stimulate these 5-HT1A autoreceptors, and this immediate action may explain the side effects those are caused by SSRIs when treatment is initiated. Over time, the increased 5-HT acting at these somatodendritic 5-HT1A autoreceptors causes them to downregulate and become desensitized. The time course of this correlates with the onset of therapeutic action. 5-HT is no longer inhibiting its own release. The serotonin neuron is therefore disinhibited. This results in a flurry of 5-HT release from the axons and an increase in neuronal impulse flow and release of serotonin from the axon terminal. 5-HT is now building in the synapse. This sends information to the cell nucleus of the postsynaptic neuron to issue instructions to downregulate these postsynaptic receptors as well. The time course of this desensitization correlates with the onset of tolerance to the side effects of SSRIs. Unique properties of each SSRI. The not so selective serotonin reuptake inhibitors. FLUOXETINE. FLUOXETINE mainly has 5-HT2C antagonistic properties. In addition, it has antagonistic actions on NRI, SERT and NET. Its activating effects may be due to its action on 5-HT2C receptors. The NRI actions may be clinically relevant only at very high doses. It's also an inhibitor at CYP, 2D6 and 3A4. Interestingly, blocking serotonin action at 5-HT2C receptors disinhibits, that is, enhances release of both NE and DA. And this happens even from the first dose and has an energizing and fatigue reducing effect. This mechanism is perhaps best matched to depressed patients with a reduced positive effect, hypersomnia, psychomotor retardation, apathy and fatigue. But then the bad news is that it is less matched to patients with agitation, insomnia and anxiety, who may experience unwanted activation and even panic attacks. FLUOXETINE has a long half-life of around 2 to 3 days and its active metabolite has even a longer half-life of around 2 weeks. The long half-life is advantageous in that it seems to reduce the withdrawal reactions that are characteristic of sudden discontinuation of some SSRIs. But then it also means it takes a long time to clear the drug after discontinuation and prior to starting another agent such as monoamine oxidase inhibitor. It's also available as ISO, as a once weekly oral dosage formulation. Other antidepressants with 5-HT2C antagonistic properties include mirtazapine, agomelatine, and several atypical antipsychotics including quetiapine, olanzapine, escitalopram, and clozapine. SERTRALINE. SERTRALINE has SERT and DAT antagonistic actions and sigma-1 binding. But DAT inhibitory action is weaker than the SERT inhibitory actions. But it may be enough to cause improvement in energy, motivation, concentration, especially when added to another action such as SERT inhibition. Anecdotal observations claim the mild and desirable activating actions of SERTRALINE in some patients with atypical depressions may improve hypersomnia, low energy, and mood reactivity. Some even add bupropion to SERTRALINE, thus adding together the weak DAT inhibitory properties of each. Like FLUOXETINE, overactivation of some patients might lead to panic disorders, thus requiring slower dose titration in some patients with anxiety symptoms. The physiological function of sigma-1 sites is still a mystery and thus sometimes called the sigma enigma. This action might contribute to its anxiolytic effects and especially its effects in psychotic and delusional depression, thus contributing both to anxiolytic actions and to antipsychotic actions useful in schizoaffective disorders. PAROXETINE. It has M1, NET and SERT antagonistic actions. Inhibits the enzyme nitric oxide synthetase and is preferred by many clinicians for patients with anxiety symptoms as it is more calming, even sedating, in early part of the treatment. Also has a weak NET inhibitory property, especially at high doses. As mentioned, it inhibits the enzyme nitric oxide synthetase, which could theoretically contribute to sexual dysfunction, especially in men, and is also notorious for causing withdrawal reactions upon sudden discontinuation with symptoms such as akathisia, restlessness, gastrointestinal symptoms, dizziness and tingling. It is also a potent inhibitor of CYP 2D6 and is available in controlled release formulations which might mitigate some of its side effects including discontinuation reactions. FLUVOXAMINE. It has SERT antagonistic actions and sigma-1 binding. Interestingly, it was never officially approved for depression in the US, thus it is considered more of an agent for the treatment of OCD and anxiety. Its interaction at the sigma-1 site is more potent than for SERTRALINE and as previously stated is linked to both anxiety and psychosis and thus effective in schizoaffective disorders. Recent studies suggest that FLUVOXAMINE may be an antagonistic at these sigma-1 receptors. It is now available in controlled release formulations, making once-a-day administration possible. Recent trials show impressive remission rates in both OCD and social anxiety disorders, as well as possible less peak dose sedation. CITALOPRAM. It's an SSRI with a good and a bad enantiomer and is antagonist at SERT, RS and H1. The two enantiomers R and S are mirror images of one another. The mixture of these enantiomers is known as racemic citalopram or just citalopram. The antihistaminic properties that reside with the R enantiomer has favorable findings in the treatment of depression in the elderly. It is somewhat inconsistent at lower doses and often requires dose increase for optimization. But this is also limited due to the potential for QTC prolongation. Evidence also suggests that the R enantiomer may actually interfere with the ability of the active S enantiomer to inhibit SERT, causing reduced net therapeutic actions, especially at low doses. Escitalopram. It is the quintessential SSRI. And the solution to the just mentioned problem is to remove the unwanted R enantiomer and thus the antihistaminic properties, eliminating dose restrictions and avoiding QTC prolongations. Considered perhaps the best tolerated SSRI with the fewest CYP interactions. Serotonin partial agonists / reuptake inhibitors known as SPARIS. These have SERT inhibition as well as 5-HT1A partial agonism. One example being the new antidepressant introduced in the US called VILAZODONE. Though not completely identical, this action has been achieved in the past by adding atypical antipsychotics such as quetiapine or aripiprazole, which has 5-HT1A partial agonist actions to SSRIs or SNRIs. And this can also be attained by augmenting SSRIs or SNRIs with 5-HT1A partial agonist BUSPIRONE. BUSPIRONE is generally dosed so that about 10 to 20% of 5-HT1A receptors are occupied, and the SSRI is dosed so that around 80% of SERTs are blocked, while VILAZODONE is dosed so that about 50% of both SERT and 5-HT1 receptors are occupied. But BUSPIRONE and its active metabolite 6-hydroxybuspirone are weaker 5-HT1A partial agonists than VILAZODONE and are estimated to occupy fewer 5-HT1A receptors. These 5-HT1A partial agonists are a type of artificial serotonin, selective especially for presynaptic somatodendritic 5-HT1 autoreceptors, and action occurs immediately after the drug is given. They hypothetically causes faster and more robust elevation of synaptic 5-HT. The downstream actions of 5-HT1A receptors lead to enhanced dopamine release, and this may be hypothetically responsible for the observed reduction in sexual dysfunction seen in patients with this combination as compared to SERT inhibition alone. As the rapid increase in serotonin is not well tolerated, especially with GI side effects, dose titration must be slowed. Serotonin norepinephrine reuptake inhibitors. Adding NET inhibition causes widening of the reach of these antidepressants to the monoamine neurotransmitter systems throughout more brain regions. Venlafaxine repeatedly seems to have greater antidepressant efficacy as the dose increases due to recruiting more and more NET inhibition. One area where SNRIs have established clear efficacy is the treatment of multiple pain syndromes, and also may have greater efficacy than SSRIs in treatment of vasomotor symptoms associated with premenopause, although this is not well established. As have previously been stated, NET inhibition increases DA in prefrontal cortex. Thus, commonly called dual action serotonin norepinephrine agents actually have a third action on dopamine in the prefrontal cortex. But they are not full triple action agents since they do not inhibit the DAT. SNRIs can perhaps be considered to have 2.5 actions, that is, they also boost dopamine specifically in prefrontal cortex, which is associated with several symptoms of depression. Although SERTs and NETs are abundant in the prefrontal cortex, the DATs are very few. That means that dopamine can diffuse away from the synapses and therefore can exert its action within a larger radius. But as studied in previous chapters, dopamine is also taken up by NET. In fact, NET has a greater affinity for DA than NE. NET blockade also lead to an increase in synaptic dopamine. Venlafaxine. Depending upon the dose, venlafaxine has different degree of inhibition of 5-HT reuptake, which is potent and robust even at low doses, versus norepinephrine reuptake, which is robust only at higher doses. It is controversial whether venlafaxine or other SNRIs has greater efficacy in major depression than SSRIs. But it seems plausible given the two mechanisms and the boosting of two monoamines. It is approved as well as widely used for several anxiety disorders as well. Adding NET inhibition likely accounts for two side effects of venlafaxine in some patients, that is, sweating and elevated blood pressure. It is available as an extended release formulation for once daily administration. It also significantly reduces side effects, especially nausea. But even in controlled release formulation, it can cause withdrawal reactions, sometimes quite bothersome, especially after sudden discontinuation after high dose long-term treatments. It's converted to its active metabolite DESVENLAFAXINE by CYP2D6. Coming to DESVENLAFAXINE. It has greater net inhibition related to SERT inhibition as compared to its parent drug venlafaxine. The variability in plasma levels of venlafaxine versus DESVENLAFAXINE is also due to genetic polymorphism of CYP2D6, such that poor metabolizers will shift the ratio towards the parent, thus reduce the relative amount of net inhibition. As a result, it can be somewhat unpredictable how much net inhibition a given dose of venlafaxine will have in a given patient at a given time, whereas this is more predictable in DESVENLAFAXINE. Studies have shown promising but inconsistent results for VMS in premenopausal women with some SSRIs as well as with alpha-2 agonist clonidine and even with anticonvulsant agent gabapentin. Interestingly, the most promising result to date seemed to be with SNRI DESVENLAFAXINE and may provide an alternative to ERT. However, it is not formally approved. The proposed mechanism of action being dysregulation of neurotransmitter systems within hypothalamic thermoregulatory centers by fluctuation of estrogen levels that lead to neurotransmitter deficiency that trigger both VMS and depression. And due to the loss of expression of sufficient number of brain glucose transporters due to low concentration of estrogen, many women continue to experience VMS postmenopausally. This in turn causes insufficient CNS transport of glucose, which would be detected by hypothalamic centers that would react by triggering a non-adrenergic alarm, with vasomotor response, increased blood flow to the brain, and compensatory increase in brain glucose transport. SNRI treatment could reduce this overactive hypothalamus. Observations suggest that SSRI seem to work better in women in the presence of estrogen. Thus, SSRI may have more reliable efficacy in premenopausal as well as postmenopausal women who are undergoing ERT. By contrast, SNRI seem to have a consistent efficacy in both pre- and postmenopausal women whether they are undergoing ERT or not. Duloxetine. This SNRI has slightly more potent SERT than net inhibition and has transformed how we think about depression and pain. Somatic pain was conceptualized classically as different from psychic pain and depression due to something wrong with the body and not due to something wrong with emotions. Somatic pain was thus not thought to be caused by depression, although depression could supposedly make it worse. Therefore, somatic pain was not treated with antidepressants. Studies with duloxetine has changed all this. Not only does this SNRI relieve depression in absence of pain, but it also relieves pain in the absence of depression. As we have studied, painful physical symptoms are frequently associated with major depressive episodes and are also one of the leading residual symptoms after treatment with antidepressants. All sorts of pain are improved by duloxetine, such as diabetic peripheral neuropathic pain, fibromyalgia, chronic musculoskeletal pain associated with osteoarthritis, as well as low back problems. Interestingly, the role of net inhibition seems to be critical not only for the treatment of painful conditions with or without depression, but also in the treatment of cognitive symptoms in depression that are prominent in geriatric depression, a consequence of net inhibition in prefrontal cortex. Duloxetine can be given once a day after the patient has had a chance to become tolerant, initiating at twice daily dosing. Another plus is that duloxetine may have lower incidence of hypertension and milder withdrawal reactions than venlafaxine. It is also an inhibitor of CYP2D6. MILNACIPRAN. Interestingly, in US it is not approved for depression but is approved for fibromyalgia. It is a bit different from other SNRIs in that it is relatively more potent net than SERT inhibitor. And as previously noted, a robust net inhibition suggests that it may be particularly useful in chronic pain-related conditions. It also has a favorable pharmacological profile for the treatment of cognitive symptoms, including cognitive symptoms of depression, as well as cognitive symptoms frequently associated with fibromyalgia, sometimes called fibrofog. It can be more energizing and activating than other SNRIs. Its enantiomer, levomilnacipran, is in clinical development as an antidepressant. But milnacipran may cause more sweating and urinary hesitancy because of its robust pro-noradrenergic actions at bladder alpha-1 receptors than some other SNRIs. An alpha-1 antagonist can reduce these symptoms. It is generally given twice daily because of its shorter half-life. Norepinephrine dopamine reuptake inhibitors, NDRIs. Bupropion. Its mechanism of action remains controversial among some experts. Leading hypothesis being it inhibits the reuptake of both DAT and NET. Interestingly, PET scans suggest that no more than 20 to 30% and perhaps as little as 10 to 15% of striatal DATs may be occupied at therapeutic dosage of bupropion, and the net occupancy is expected to be in the same range. It is metabolized to a number of active metabolites, some of which are more potent. The most potent of these is the positive enantiomer of the 6-hydroxy metabolite. It is also known as ridafaxine. It has a rapid, short-acting and a high degree of DAT occupancy, which is characteristic of abusable stimulants such as cocaine. But bupropion has just enough DAT inhibition with slow enough onset and long enough duration of action to make it an antidepressant. It has proven effective in treating nicotine addiction and is consistent with the possibility that it is occupying DATs in the striatum and nucleus accumbens in a manner sufficient to mitigate craving but not sufficient to cause abuse, and appears especially useful in targeting the symptoms of reduced positive effect within the affective spectrum, such as loss of happiness, joy, interest, pleasure, energy, enthusiasm, alertness, and self-confidence. Originally marketed in the US as an immediate release formulation with thrice-a-day administration. Development of a twice-a-day formulation, that is SR, and more recently once-a-day formulation, that is XL, has not only reduced the frequency of seizures at peak plasma drug levels but has also increased convenience and enhanced compliance as well. Interestingly, it does not appear to cause the bothersome sexual dysfunction that frequently occurs with antidepressants that act on SERT inhibition, probably because it lacks a significant serotonergic component to its mechanism of action. Symptoms of dopamine deficiency syndrome and reduced positive effect frequently benefit from switching to bupropion or augmenting SSRI or SNRI treatment with it. Selective norepinephrine reuptake inhibitors, NRIs. The first truly selective non-adrenergic reuptake inhibitor to be marketed in Europe and other countries was reboxetine, and the first in the US was atomoxetine. Both lack the additional and undesirable binding properties of the tricyclics. But reboxetine testing in the US suggested inconsistent efficacy in major depression with the possibility of being less effective than SSRIs. And atomoxetine was never developed as an antidepressant but is marketed for the treatment of ADHD. But as stated previously, NET inhibition not only raises NE but also raises DA levels in prefrontal cortex. And as expected, higher degree of NET occupancy of selective NET inhibitors may be necessary for optimal efficacy for either depression or ADHD if there is no simultaneous SERT or DAT inhibition. Interestingly, high degree of selective NET inhibition, although often activating, can also be sedating in some patients. This might be due to over-tuning noradrenergic input to cortical pyramidal neurons. A new selective NET inhibitor, sometimes also called NERI, is adivoxetine, is in testing as an augmenting agent to SSRIs in depression. Depression can alter circadian rhythm, causing a phase delay in sleep-wake cycle, the degree of which correlates with the severity of depression. Agomelatine. Numerous other physiological measurements of this rhythm are also altered, such as flattening of the daily body temperature cycle, elevation of cortisol secretion throughout the day, reduction of melatonin secretion that peaks at night, and reduction of BDNF and neurogenesis that also peaks at night. It is even possible that depression is due to this broken circadian clock. Interestingly, numerous genes operate in a circadian manner, sensitive to light-dark rhythms, and are called clock genes. The abnormalities in these clock genes have been linked to mood disorders. Melatonergic actions combined with monoaminergic actions can resynchronize this rhythm in depression, essentially fixing the broken clock and thereby exerting an antidepressant effect. Agomelatine has agonist actions at MT1 and MT2 receptors and antagonistic actions at 5-HT2C receptors. Normally, serotonin binding at 5-HT2C receptors at GABA interneurons in the midbrain inhibits both norepinephrine and dopamine release in the prefrontal cortex. But when 5-HT2C antagonists such as agomelatine binds to 5-HT2C receptors on GABA interneurons, it prevents serotonin from binding there and thus prevents inhibition of norepinephrine and dopamine release in the prefrontal cortex. In other words, it disinhibits the release. 5-HT2C antagonistic actions are, as mentioned, is a property of antidepressant FLUOXETINE and MIRTAZAPINE and the atypical antipsychotics with antidepressant actions such as quetiapine and olanzapine. 5-HT2C receptors are not only located in the midbrain raphe and prefrontal cortex where they regulate the release of dopamine and norepinephrine, they are also localized in the suprachiasmatic nucleus of the hypothalamus, the so-called brain space maker where they interact with melatonin receptors. When light enters through the eye, it is translated via the retinohypothalamic tract to HCN within the hypothalamus. The HCN in turn signals the pineal gland to turn off melatonin production. And in reverse, darkness signals the pineal gland to produce melatonin. Melatonin in turn can act on the SCN to reset circadian rhythms. Both melatonin and 5-HT2C receptors fluctuate in a circadian manner, with high receptor expression at night or dark and low receptor expression in the day or light. In depression, however, circadian rhythms are out of sync, including low melatonin secretion at night. Agomelatine, by stimulating melatonin receptors in SCN and simultaneously blocking 5-HT2C receptors there as well, appear to resynchronize circadian rhythms. The combination of 5-HT2C antagonism plus MT1 and T2 agonism creates numerous biological effects that are not triggered by either mechanism alone, namely enhancing neurogenesis and BDNF, resetting sleep-wake and dark light phases, decreasing stress-induced glutamate release, regulating downstream signal transduction cascades and clock genes, resynchronizing circadian rhythms, and more critically, antidepressant actions. Alpha-2 antagonistic actions and mirtazapine. Alpha-2 antagonism is another way to enhance the release of monoamines. Norepinephrine turns off its own release by interacting with presynaptic alpha-2 autoreceptors on noradrenergic neurons. Therefore, when an alpha-2 antagonist is administered, norepinephrine can no longer turn off its own release, and noradrenergic neurons are thus disinhibited, such as those in raphe and in the cortex. And as seen in previous chapters, norepinephrine can turn off serotonin release as well by interacting with presynaptic alpha-2 heteroreceptors on serotonergic neurons. Alpha-2 antagonists block norepinephrine from turning off serotonin release as well. Because alpha-2 heteroreceptors on serotonin axon terminals are blocked even in the presence of norepinephrine. Therefore, serotonin neurons become disinhibited and serotonin release is enhanced. Thus, alpha-2 antagonists acting at serotonin axon terminals cut the brake cable of noradrenergic inhibition, in which norepinephrine steps on the brake to prevent 5-HT release. That's the second mechanism in which norepinephrine neurons from locus coeruleus intervene the cell bodies of serotonergic neurons in the midbrain raphe and stimulate serotonin release from serotonin axon terminals via postsynaptic alpha-1 receptors on the serotonin cell bodies. Thus, when alpha-2 antagonist causes norepinephrine release in the raphe, this also causes stimulation of postsynaptic alpha-1 receptors on serotonin cell bodies in the raphe, thereby provoking more serotonin release from the downstream axon terminals such as those in the cortex. This is like stepping on the serotonin accelerator. Thus, alpha-2 antagonists both cut the brake cables and step on the accelerator to facilitate serotonin release. These two mechanisms, that is, the monoamine transport blockade and alpha-2 antagonism, are synergistic. For this reason, the alpha-2 antagonist mirtazapine is often combined with SNRIs for treatment of cases that do not respond to SNRIs alone. This combination is sometimes called the California rocket fuel. Mirtazapine does not block any monoamine transporter. However, it not only blocks alpha-2 receptors but has additional potent antagonistic actions upon 5-HT2A, 2C, 3 and H1 histaminic receptors. Two other alpha-2 antagonists that are marketed as antidepressants are mianserine, that is marketed worldwide except in US, and cetabtaline, that is marketed only in Japan. 5-HT2C antagonistic actions theoretically contribute to the antidepressant effects of mirtazapine and mianserine as well. The H1 antihistaminic actions of mirtazapine and mianserine should theoretically relieve insomnia at night and improve anxiety during the day, but could also cause drowsiness during the day. The combined 5-HT2C and H1 antagonistic properties of mirtazapine could also cause weight gain. 5-HT3 receptors are localized in the chemoreceptor trigger zone of the brainstem, where they mediate nausea and vomiting, and in the gastrointestinal tract, where they mediate nausea, vomiting, as well as bowel motility. Blocking these receptors can therefore protect against serotonin-induced GIT side effects. They also regulate the release of various neurotransmitters, especially norepinephrine and acetylcholine. As we know, serotonin acting at 5-HT3 receptors reduces the release of these neurotransmitters, so blocking 5-HT3 receptors can cause disinhibition of these. Thus, agents such as mirtazapine with 5-HT3 antagonistic properties should enhance the release of various neurotransmitters. Potent 5-HT3 antagonism is also one of the 5 multimodal pharmacological actions of an experimental antidepressant vortioxetine in late stages of clinical trials. Serotonin antagonist reuptake inhibitors, SARIS. The prototype drug that blocks serotonin 2A and 2C receptors as well as serotonin reuptake is trazodone. Vilazodone is another SARI with robust 5-HT2A and weaker 5-HT2C antagonistic properties as well as SERT inhibition, but is no longer commonly used because of liver toxicity. Trazodone is a very interesting agent since it acts like 2 different drugs depending upon the dose and the formulation. Different drug at different doses. Combined actions of 5-HT2A 2C antagonism with SERT inhibition only occur at moderate to high doses. Lower doses of trazodone are frequently used for the effective treatment of insomnia. These lower doses exploit its antagonistic actions at 5-HT2A, H1 and alpha-1 receptors. But these low doses does not adequately exploit its SERT and 5-HT2C inhibition properties. Since insomnia is one of the most frequent residual symptoms of depression, trazodone can augment the efficacy of other antidepressants. To get an antidepressant action, though, the dose must be raised to recruit SERT inhibition, which raises the serotonin levels. However, what happens when trazodone raises serotonin levels is different from what happens when SSRI or SNRI does this, as these increase serotonin levels by acting at all the serotonin receptors, with therapeutic actions by stimulating 5-HT1A receptors and with side effects by concomitantly stimulating 5-HT2A and 2C receptors that theoretically causes sexual dysfunction, insomnia and anxiety. But by trazodone, 5-HT1A receptors are stimulated by raising serotonin levels when SERT is inhibited, but 5-HT2A and 2C receptors are blocked. This pharmacological profile alters the clinical profile and explains why it is not associated with sexual dysfunction and insomnia, and in fact is a treatment option for insomnia and anxiety. The same clinical profile applies to other agents with 5-HT2A antagonistic properties such as atypical antipsychotics and mirtazapine. Also, the combination of 5-HT2A antagonism with 5-HT1A stimulation causes enhancement of both glutamate and dopamine release downstream. Different drug in different formulations. Trazodone is not commonly used at high doses as an antidepressant because it has a short half-life requiring multiple daily doses and can be very sedating at antidepressant dosing levels. It comes in immediate release as well as various controlled release formulations. The immediate release formulation has a relatively rapid onset and short duration of action, and in low doses acts as hypnotic, but wearing off before the morning so that there is no hangover effect. But as can be expected at higher antidepressant doses, there can be hangover effect in the morning. Higher doses of controlled release formulations given once daily at night do not attain sedating peak levels of the immediate release and thus are antidepressants without sedation. These properties of trazodone added to SSRIs and SNRIs are likely not only to boost the efficacy of these in depression and anxiety but also have more than a hypnotic effect. Classical antidepressants, the MAO inhibitors. Discovered by accident when an anti-tuberculosis drug was observed to help depression that coexisted in some of the patients. Iproniazid was eventually found to work in depression by inhibiting the enzyme MAO. MAO inhibitors are also highly effective in certain anxiety disorders such as panic disorder and social phobias. MAO exists in two subtypes, A and B. The A form preferentially metabolizes the monoamines most closely linked to depression, that is serotonin and norepinephrine. On the other hand, B form preferentially metabolizes trace amines such as dopamine, tyramine and phenylethylamine. Noradrenergic and dopaminergic neurons are thought to contain both MAO A and B, with perhaps MAO A activity predominant, whereas serotonergic neurons are thought to contain only MAO B. MAO A is the major form of this enzyme outside the brain, with the exception of platelets and lymphocytes, which has MAO B. Interestingly, brain MAO A must be inhibited for antidepressant efficacy. Inhibition of MAO B is not effective as an antidepressant. But when this enzyme is selectively inhibited, it can boost the actions of concomitantly administered levodopa in Parkinson's disease. MAO B is also thought to convert some environmentally derived amine substrates called protoxins into toxins that may cause damage to neurons and possibly contribute to cause or decline of function in Parkinson's disease. Thus, inhibiting MAO B might slow the degenerative course of various neurodegenerative disorders, including Parkinson's disease. Two MAO inhibitors, selegiline and residulane, when administered orally in doses selective for inhibition of MAO B, are approved for use in patients with Parkinson's disease. When MAO B is inhibited simultaneously with MAO A, there is a robust elevation of dopamine as well as of serotonin and norepinephrine, and theoretically provides the most powerful antidepressant efficacy across the range of depressive symptoms from diminished positive effect to increased negative effect, and therefore is a good therapeutic strategy to treat refractory treatment-resistant symptoms. Recent brain imaging studies show elevated levels of MAO A activity in depressed patients, and patients who recover from their depression with SSRI treatments but do not simultaneously recover normal levels of MAO A have a continuing vulnerability to relapse. The MAO A as a potential cause of depression or of some form of treatment resistance comes from the discovery of protein called R1 or repressor 1. It controls the expression of MAO A. R1 may be depleted in both treated and untreated depression, causing a lack of repression of MAO-A synthesis and thus an increase in MAO-A activity in depression. Now, to prescribe MAO-A inhibitors, it is necessary to understand how to manage two issues. First, diet and then drug interactions. The dietary tyramine interaction. One of the biggest barriers is that a patient taking one of these drugs may develop a hypertensive crisis after ingesting tyramine in the diet. Normally, the release of norepinephrine by tyramine is inconsequential because MAO-A safely destroys this released norepinephrine. The body normally has a huge capacity for processing tyramine, and the average person is able to handle approximately 400 milligrams before blood pressure rises. But when MAO-A is inhibited, it may take as little as 10 milligrams of dietary tyramine to increase blood pressure and cause hypertensive crisis, defined by a diastolic blood pressure of more than 120. Potentially fatal reaction is characterized by occipital headache that may radiate frontally, palpitations, neck stiffness or soreness, nausea, vomiting, sweating, dilated pupils, photophobia, tachycardia or bradycardia with constricting chest pain. Since the tyramine reaction is sometimes called a cheese reaction, there is a myth that all cheese must be restricted for patients taking MAO inhibitors. However, this is only true for aged cheese and not for most processed cheese. Also, it is not true that patients taking MAO inhibitors must avoid all wine and beer, as canned beer and bottled beer are low in tyramine generally. Only tap and non-pasteurized beers must be avoided, and many wines are actually quite low in tyramine. But should always counsel patients taking classic MAO inhibitors about diet and keep up to date with the tyramine content. There are two MAO inhibitors that does not require any dietary restrictions. STAL'S is selective MAO-B inhibitor at low oral doses, but also does not inhibit MAO-A in the brain and is therefore not an antidepressant. However, delivering it through a transdermal patch allows inhibition of both MAO-A and B in the brain, while largely bypassing inhibition of MAO-A in the gut. By the time the drug recirculates to the intestine and liver, it has much decreased levels and significantly inhibits only MAO-B in these tissues, and thus no dietary tyramine restrictions are necessary. Another mechanism to theoretically reduce risk of tyramine reactions is to use reversible inhibitors of MAO-A. REMAs can be removed from the enzyme by competitive inhibition by MAO-A substrates. That is, if norepinephrine levels are high enough, they can displace the REMA from MAO-A and the enzyme activity is restored. However, the REMA moclobamide still carries the dietary restriction warnings of irreversible MAO inhibitors. Now let's discuss drug-to-drug interactions of MAO inhibitors. Some interactions can be dangerous or even lethal. There are two general types: those that can raise blood pressure by sympathomimetic actions and those that can cause potentially fatal serotonin syndrome by serotonin reuptake inhibition. MAO inhibitors and sympathomimetics to avoid or to administer with caution. Drugs that boost adrenergic stimulation when added to MAO inhibitors can cause potentially dangerous hypertensive reactions. Decongestant stimulates postsynaptic alpha-1 receptors directly or indirectly, which constricts nasal blood vessels. This combined with MAO-A inhibition may be sufficient to cause hypertension or even hypertensive crisis. This is less likely with topical or intranasal administration and in those who are not vulnerable to hypertension. Other agents include stimulants and some antidepressants. For patients with cold or upper respiratory infections, antihistaminics are safe with the exception of those that are also serotonin reuptake inhibitors. Example, brome or chlorpheniramine. Cough medications with expectorants or codeine are safe but avoid dextromethorphan. MAO inhibitor interactions with anesthetics. Both general and local anesthetics that contain epinephrine can cause changes in blood pressure. You have to choose an agent that does not contain vasoconstrictors. For elective surgeries, one should wash out the MAO inhibitors 10 days prior to the surgery. And for urgent surgeries, one can cautiously use a benzodiazepine, mivacurium, morphine, codeine, etc. Try to avoid MAO inhibitors with serotonergic agents, such as agents that inhibit serotonin reuptake. In combination, these two mechanisms can cause excessive stimulation of postsynaptic serotonin receptors, which has the potential to cause fatal serotonin syndrome or serotonin toxicity. The clinical features of serotonin toxicity can range from mild end of the spectrum with symptoms like migraines, myoclonus, agitation and confusion to the severe end of the spectrum with symptoms like hypothermia, seizures, coma, cardiovascular collapse, permanent hypothermic brain damage or even death. Early diagnostic criteria for serotonin syndrome were developed by Sternbach However, these criteria lack both sensitivity and specificity. On the other hand, Gilman's group in Australia developed a set of diagnostic criteria called the Hunter serotonin toxicity criteria, which needed only 5 of the clinical features associated with serotonin toxicity, which were clonus, agitation, diaphoresis, tremors, and hyperreflexia. Therefore, as stated again and again, never combine agents that has potent serotonin reuptake inhibition with agents that cause substantial MAO inhibition. And these includes SSRIs, SNRIs, and the TCA clomipramine. Opioids that block serotonin reuptake, especially meperidine, but also tramadol and dextromethorphan must be avoided. Serotonin 1A partial agonism or the pro-serotonergic actions of lithium could also contribute to serotonin syndrome in combination with MAO inhibitors. These interactions mentioned are not actual contraindications, but such medications can be administered with caution. MAO inhibitors interactions with TCAs. MAO inhibitors are formally contraindicated for patients taking antidepressants that are norepinephrine reuptake inhibitors, such as most tricyclic antidepressants, and may result in the aforementioned hypertensive reaction. But with the exception of clomipramine, a potent serotonergic reuptake inhibitor, other TCAs can be combined with MAO inhibitors with caution for severely treatment-resistant patients by experts doing careful monitoring. One should start the MAO inhibitors at the same time as the tricyclic antidepressants, both at a low dose, after an appropriate drug washout. Then, one should alternately increase the doses of these agents every few days to weeks as tolerated. Again, the MAO inhibitor should not be started first. Cyclobenzaprine, carbamazepine, and oxcarbazepine are structurally related to TCAs. However, these agents do not block serotonin or norepinephrine reuptake and thus can be used with caution. MAO inhibitors interactions with opioids. There is actually no dangerous pharmacological interactions. But as previously stated, the reason why some of these opioids must be avoided, especially meperidine, possibly methadone and tramadol, is that they have concomitant SERT inhibition, while another tapentadol has NET inhibition. Analgesics, including opioids, which are safe to administer with MAO inhibitors, are those lacking serotonin reuptake inhibiting properties, such as aspirin, acetaminophen, NSAIDs, codeine, hydrocodone. Switching to and from MAO inhibitors and bridging medications to use during these switches. One must wait at least 5 half-lives after discontinuing the serotonergic drug before starting the MAO inhibitor. For most drugs, this means around 5 to 7 days, a notable exception being FLUOXETINE, for which one must wait for 5 weeks. When switching in the other direction, one must wait at least 14 days following the discontinuation of MAO inhibitor before starting the serotonergic drug. There are many medication options depending on the individual patient's situation for managing symptoms during this period. These include benzodiazepines, Z-drug sedative hypnotics, trazodone, lamotrigine, valproate, anticonvulsants, stimulants, and atypical antipsychotics. The bottom line for MAO inhibitors. They should not be discounted as valuable treatment options for treatment-resistant depression as well as treatment-resistant anxiety disorders, such as panic disorder and social anxiety disorders, although they do require a watchful eye over dietary intake. Classical antidepressants, the tricyclics. They were discovered to block NET or both NET and SERT, but most block both serotonin and norepinephrine reuptake to some extent. Some TCAs have equal or greater potency for SERT inhibition, example being clomipramine. Others are more selective for NET inhibition, example being desipramine, nortriptyline, protriptyline, etc. In addition, some tricyclic antidepressants have antagonistic actions at 5-HT2A and 2C receptors, which could contribute to their therapeutic profile. The major limitation is that all of them share at least 4 other unwanted pharmacological actions, namely the blockade of M1, H1, alpha-1 receptors along with voltage-sensitive sodium channels. H1 receptor action, also called antihistaminic action, causes sedation and may even cause weight gain. Blockade of M1 receptors, also known as anticholinergic actions, causes dry mouth, blurred vision, urinary retention, and constipation. While the blockade of alpha-1 adrenergic receptors causes orthostatic hypotension and dizziness. And the blockade of voltage-sensitive sodium channels in heart and brain and in overdose is thought to be the cause of coma and seizures due to central nervous system actions and cardiac arrhythmias and cardiac arrest, and even death due to the peripheral cardiac actions. Clomipramine has anti-OCD effects, and many of them have anti-panic effects at antidepressant doses. Due to their side effect and potential for death in case of overdose, TCAs has fallen into second-line use in depression. Augmenting antidepressants. Alternatives or augmenting agents for antidepressants are some natural products, hormones, neurostimulation therapies, and psychotherapies. L5-methyl tetrahydrofolate as monoamine modulator. Synthesized in the body from folate or dihydrofolate in the diet, also available as a medical food by prescription called Deplin, is an important regulator of a critical cofactor for monoamine synthesis, namely tetrahydrobiopterin or BH4. The monoamine synthetic enzymes that require BH4 as a cofactor are both tryptophan hydroxylase, the rate-limiting enzyme of serotonin synthesis, and tyrosine hydroxylase, the rate-limiting enzyme not only for dopamine synthesis but also for norepinephrine. Low amounts of L-methylfolate from genetic and or environmental or dietary causes could theoretically lead to low synthesis of monoamines and may contribute to depression or the resistance of some patients to treatment with antidepressants. The second mechanism is methylation of genes silences them. L-methylfolate provides the methyl group for this silencing. If the silencing of the gene for the enzyme COMT is low, more copies of these enzymes are made, and the enzyme activity goes up, causing dopamine levels to go down, particularly in prefrontal cortex. Several genetic variants exist in enzymes that regulate L-methylfolate levels. For example, methylene tetrafolate reductase, MTHFR, C677T, and A129HC. Methionine synthase, MTR, E2756G, and methionine synthase reductase, MTRR-A66G. Studies of MTHFR and COMT in schizophrenia suggest that effects of some gene variants on the efficacy of information processing might be greater if variants of two or more particular genes are inherited together. The effect of two or more risk genes working together to increase the risk of an illness, such as depression, is known as epistasis. There is some evidence that the T variant of MTHFR conspires with the VAL variant of COMT to decrease the efficiency of information processing in DLPFC during cognitive load in schizophrenia, as having T with VAL. S-adenosylmethionine. L-methylfolate is converted into methionine and finally to SAMe, and it is possible to administer methionine or SAMe in case of deficiency. But administering these can cause buildup of the unwanted metabolite homocysteine that could interfere with epigenetic mechanisms and can also eventually deplete precursors of SAMe. Nevertheless, high doses of SAMe may be effective in augmenting antidepressants in patients with major depression. Coming on to thyroid, it acts by binding to nuclear ligand receptors to form nuclear ligand activated transcription factor, which may boost monoamine neurotransmitters as downstream consequences of thyroid's known abilities to regulate neuronal organization, arborization, and synapse formation. Brain stimulation, creating a perfect storm in brain circuits of depressed patients. Electroconvulsive therapy. Failure to respond to a variety of antidepressants, singly or in combination, is a key factor for considering ECT, and may also be utilized in urgent and severely disabling high-risk circumstances such as psychotic, suicidal, or postpartum depression. ECT is the only therapeutic agent for the treatment of depression, with the possible exception of experimental agents like ketamine, scopolamine, and sleep deprivation that is rapid in antidepressant onset, with therapeutic actions that can start even after a single treatment. The mechanism is thought to be related to the probable mobilization of neurotransmitters caused by seizure. Memory loss and social stigma are the primary problems related to ECT. Transcranial magnetic stimulation. It uses a rapid alternating current passing through the small coil placed over the scalp that generates a magnetic field, which in turn induces an electric current in the underlying areas of the brain. It depolarizes the affected cortical neurons, thereby causing nerve impulses to flow out of the underlying brain areas. Presumably, daily stimulation of DLPFC and its circuits to VMPFC and amygdala and the brainstem centers for up to an hour over several weeks causes activation of these circuits that leads to antidepressant effect by monoamine modulation. No peripheral side effects such as nausea, weight gain, blood pressure changes, or sexual dysfunction is present. Deep brain stimulation. This is an experimental treatment for the most severe form of depression. The stimulation device is a battery-powered pulse generator implanted in the chest wall like a pacemaker, and 1 or 2 leads are tunneled under the scalp and then into the brain. The most common side effects are from the procedure itself. One proposed location for electrodes is the subgenual area of the anterior cingulate cortex of VMPFC. Now let's discuss psychotherapies as epigenetic drugs. Drugs in psychotherapy may have a common neurobiological link, since both can change brain circuits and combining them may be synergistic. Bad memories of childhood trauma may trigger psychiatric disorders by causing unfavorable changes in the brain circuits. And good memories formed during psychotherapy may favorably alter the same brain circuits. The best psychotherapies to combine with drugs, particularly for the treatment of depression, are CBT and interpersonal therapies, which has a 12 to 24 week program that follows progression with a beginning, a middle, and an end. The new trial-based therapy described by De Oliveira is a version of cognitive psychotherapy that is intuitive, readily adapted by psychiatrists, and can even be fun. The patient literally puts his psychiatric symptoms and core beliefs on trial. This idea is based on the universal principle portrayed in Franz Kafka's The Trial, that human beings by their very nature are self-accusatory, and this can lead to confusion, anxiety, and existential suffering. Here, during outpatient psychotherapy, a patient's self-accusations are put on trial as distorted schemas and core beliefs that have been developed about the self by patient's inner prosecutor. Therapy seeks to point out to the patient that his symptoms and sufferings are due to his core beliefs that can be countered by activating their inner defense autonomy, and to see things in a more balanced and realistic way, and thereby relieving symptoms. Combining psychotherapy with antidepressants has the potential of making the entire outcome greater than the sum of its parts, like 1 plus 1 becoming 3. How to choose an antidepressant? One general principle upon which most agree, however, is when to switch versus when to augment. The best way to select a treatment for depression would be to follow the evidence. Unfortunately, there is little evidence for superiority and a good deal of controversy about meta-analysis. There is a preference for switching when the first treatment has intolerable side effects or when there is no response whatsoever, and to augment the first treatment with a second treatment when there is partial response to the first treatment. Symptom-based antidepressant selections. This strategy leads to the construction of a portfolio of multiple agents to treat all residual symptoms of unipolar depression until the patient achieves sustained remission. First, the symptoms are constructed into a diagnosis and then deconstructed into a list of specific symptoms, which are then matched with the brain circuits and their neurotransmitters that hypothetically mediate them. And finally, available treatment options that target these neuropharmacological mechanisms are chosen. For example, in a patient with symptoms of problem concentrating, decreased interest as well as fatigue, this approach would suggest treating both norepinephrine and dopamine with first-line antidepressants, plus augmenting agents that act on these neurotransmitters. And this can call for stopping the SSRI if this is partially the cause of these symptoms. This approach helps finding a faster way of reducing specific symptoms with more tolerable treatment selection for the patient than a purely random approach. This can also be applied to treating common associated symptoms of depression that are not components of the formal diagnostic criteria. 5 such symptoms are anxiety, pain, hypersomnia, problems with arousal and alertness, and sexual dysfunction. Therefore, to get the patient with major depression into remission, it requires targeting at least 14 of the 9 symptoms of depression. Anxiety can be reduced in patients with the same serotonin and GABA mechanisms proven to work in anxiety disorders. Hypersomnia is a common associated symptom of depression, but frequently not detected because patients who have this problem surprisingly do not often complain about it. Such patients may respond to the same agents that are effective in sleep disorders, such as agents that can boost dopamine, norepinephrine, and histamine. Painful physical and vasomotor symptoms are commonly associated with depression and can be treated with SNRIs and other approaches. Sexual dysfunction can be a complicated problem of many causes and can range from lack of libido to problem with arousal and lack of orgasm. Increasing dopamine or decreasing serotonin are the usual approaches to this set of problems, whether the patient has major depression or not. Parts of CNS with which these symptoms are usually associated with. Physical fatigue is associated with striatum and spinal cord, mental fatigue with loss of interest to DLPFC and nucleus accumbens, insomnia to hypothalamus, and concentration to DLPFC. Choosing an antidepressant for women based on their life cycle. Estrogen levels shift rather dramatically across the female life cycle and are also linked to the onset or recurrence of major depressive episodes. Incidence of depression in many ways mirrors the changes in estrogen. Estrogen levels rise during puberty, and with it, the incidence of depression skyrockets, falling again after menopause. During their childbearing years, when the estrogen is high and cycling, the incidence of depression in women is 2 to 3 times higher than in men. Depression and its treatment during childbearing years and pregnancy. There are no firm guidelines that fit all cases, and the risk-benefit ratio must be calculated, and the risk to her bonding to her baby if she does not breastfeed. ERT has been reported to be effective in some, but reserved for use only in patients resistant to antidepressants. Mothers with a prior postpartum depression who neglects to take antidepressant after subsequent pregnancy has a 67% risk of recurrence. Also, up to 90% of all postpartum psychosis and bipolar episodes occur within first 4 weeks after delivery. High-risk patients will require appropriate treatment, so the decision here is whether to breastfeed and not whether the mother should be treated. Choosing an antidepressant on the basis of genetic testing. It is already possible to obtain genotyping of numerous genes, and several genetic forms of CYP450 can be obtained to predict high or low levels of substrate drugs. These CYP genotypes can potentially explain side effects and lack of therapeutic effects in some patients, and the information can tell whether the patient is biased towards responding or not, or tolerating or not. SLC6A4 variant of SERT has poor response, slow response, or poor tolerability to SSRIs and SNRIs. Some call this process the weight of evidence and others equipoise, whether the genetic information will enrich the prescribing decisions. Should antidepressant combinations be the standard for treating unipolar major depressive disorders? The paradigm of prescribing a sequence of monotherapies, each with a single mechanism of therapeutic action for major depression, is rapidly changing to one of administering multiple simultaneous pharmacological mechanisms, often with 2 or more therapeutic agents. These particular combination or combos have enjoyed widespread use, even though there is little actual evidence-based data from clinical trials. Several combinations of SSRIs, SNRIs with other agents have been mentioned, like atypical antipsychotics, lithium, BUSPIRONE, trazodone, hypnotics, thyroid, L-methylfolate, same, neurostimulation, and psychotherapies. Several additional combos, often called heroic combos because they have strong anecdotal experience of efficacy in some difficult cases of treatment-resistant depression. Triple action combos of SSRI, SNRI plus NDRI. SSRI plus NDRI gives single boost for serotonin, norepinephrine, and dopamine. SNRI plus NDRI gives single boost to serotonin and dopamine and a double boost to norepinephrine. California rocket fuel, SNRI plus mirtazapine. Adding the enhanced serotonin and norepinephrine release from inhibiting both reuptake by SNRI to disinhibiting their release by alpha-2 antagonist actions of mirtazapine. Additional pro-dopaminergic actions result from the combination of norepinephrine reuptake blockade in prefrontal cortex due to SNRI actions with 5-HT2C actions of mirtazapine disinhibiting dopamine release. This combination can provide a very powerful antidepressant action for some patients with unipolar major depressive episodes. The 5-HT is quadruple boosted, reuptake blockade, alpha-2 antagonism, and 5-HT2A and 2C antagonism. NE is also quadruple boosted with the same mechanism. There may even be a double boost for dopamine with 5-HT2A and 2C antagonism. Arousal combos. Frequent complaints of residual fatigue, loss of energy, motivation, sex drive, and problem concentrating or with alertness may be approached by combining either a stimulant or modafinil with SNRI to recruit triple monoamine action and specially enhancing dopamine. In this, 5-HT and DA are single boosted and NE is double boosted. With SNRI in combination with modafinil, 5-HT and NE are single boosted by SNRI, while DA is single boosted by modafinil. The stimulant, lisdexamfetamine, which links the amino acid lysine to the stimulant D-amphetamine, is in late stage of clinical testing as augmenting agent to SSRI and SNRIs in treatment-resistant depression. Future treatments of mood disorders. Triple reuptake inhibitors or TRIs or serotonin, norepinephrine and dopamine reuptake inhibitors SNDRIs are in clinical testing. And these are some of the examples. Multimodal agents. This can include reuptake blockade at SERT-NET with actions at G protein receptors and with actions at ion channel receptors. One such agent already discussed is VILAZODONE, which has combination of SERT plus 5-HT1A partial agonist actions. Another one is vortioxetine. It acts via all 3 modes with combination of 5 pharmacological actions: reuptake blockade mode, G protein receptor mode, and ion channel mode. This increases the release of 5 different neurotransmitters, not only triple monoamine actions on 5-HT, NE and DA, but also increases the release of acetylcholine and histamine. This suggests efficacy without sexual dysfunction and a potential for either pro-cognitive effects or enhanced antidepressant efficacy, as compared to agents with fewer mode of action and effects on fewer neurotransmitters. NMDA blockade. Infusion of sub-anesthetic dose of ketamine can exert an immediate antidepressant effect in patients with treatment-resistant unipolar or bipolar depression and can immediately reduce suicidal thoughts. But the effects are not sustained for more than few days. Ketamine acts as an open channel inhibitor at NMDA glutamate receptors and cause downstream release of glutamate, which stimulates AMPA and mGluR receptors while NMDA receptors are being blocked by ketamine action. Ketamine's action at NMDA receptors are not unlike what is hypothesized to occur due to neurodevelopmental abnormalities that occurs at NMDA synapses in schizophrenia and produces schizophrenia-like syndrome in humans. Hypothesis for why ketamine has antidepressant actions proposes that stimulation of AMPA receptors first activates ERK/AKT signal transduction cascade. This then triggers the mTOR that causes the expression of synaptic proteins, leading to an increased density of dendritic spines, which can be seen soon after ketamine is administered. So hypothetically, it increases the dendritic spines that causes a rapid onset of antidepressant effect. One candidate for oral ketamine that acts on NMDA receptors is the cough medication dextromethorphan.